Do me a favor, before we introduce ourselves, would you introduce yourself and the panel for us, and then we'll get started here.
Karthik here, and then on the panel we have Dr. Fabrizio. We have, Matthew Bunty's here. We have Dr. McKinsey, and we have Dr. Snyder.
Uh-oh.
I know.
Doctor, who was the last one?
Darren Snyder.
Oh boy, I'm bad. I'm outnumbered for this case. I think I've been set up. Okay.
I think it was a total setup. I totally agree with you. Not that you need any help, but we're all here, so.
No, I am glad to have everybody in that audience here. These are good friends, as I count as colleagues, and everything we do in our space is a collaborative effort. So any comments will be taken in that spirit. So, welcome back to Kingsport and to Ballard Holston Valley Medical Center. We're honored to be presenting and transmitting cases to the New York Endovascular Symposium. Let me introduce the team that's working very hard and is going to continue to work hard. Sorry about that, after we're done here. To my right, Victoria Miller, who'll be running the table here and keeping me under control, the hardest job in the room. Behind us, we have the talents of Alexis Mullins, who you saw this morning's live case. Jessica Linkus, you'll see her runoff skills in just a moment. The nursing talents of Michelle Tolliver, and then we have industry support of Stephen Ross, and in the back we have Josh Gray as well from Philips. So again, thanks for everybody for their support. All right, we have a good case. Let's show it to you.
All right.
Can you? All right. So here's our first slide. Disclosures are listed here. Next slide. All right, this is a very nice gentleman, severe coronary disease. He's had bypass surgery in 2014. We then subsequently, his vein grafts are all occluded, so we've done some rotational atherectomy and drug-eluting stenting in a lot of vessels, including the left main, and he's got an EF of 25%. That said, he's very active and functional, and I met him last in March of this year for symptomatic right internal carotid artery. He had stenting with embolic protection. With proximal protection, he did well. Risk factors that you see there, he had right common femoral artery stenosis, which was pretty bad during our right carotid intervention. But at that time, he didn't want intervention. He thought his symptoms were mild to moderate, so he was treated medically and continued with walking program. However, he now has severe right exertional claudication at 50 feet. Now important, as you see in orange, because of the successful University of Tennessee football program. They're undefeated, you may have noticed. Then he's a Vol fan, and you know, now it's hitting, when he tries to go up to the stands, it's mighty hard for him to walk, and he has a mild component of rest vein, but no ulcers. Next slide, please. Again, severe symptoms despite maximized medical therapy, as you've seen there, and smoking cessation and a walking program. ABIs were moderately low at rest, but dropped a lot with exercise. And his duplex showed very significant turbulence in the right common femoral artery, calcified plaque, and monophasic signals in the profunda and the SFA. So we'll look at some CT angiogram images. Next slide, please. And here you can see the significant calcification in the right common femoral artery and the axial images as well as the coronal images as well. Next slide. So lots of discussions. I've got 6 vascular surgeons in our group, good friends, and discussions with the patient about all the options and here for intervention of the right common femoral artery.
I guess you just opened up a can of worms with that CAT scan, so I think I saw Dr. McKinsey's eyes.
No, I see the fishermen out there waiting.
I know, right?
A can of worms.
You just gave them the bait.
I heard drooling on the other end of the podium, so get the drool off your microphones there, my surgical colleagues. All right, so let's go to our fluoro here. Here's our axis on the left. Here's another plate 8, most likely with renal arteries, which are pretty significant, quite honestly, more than what was appreciated on the CT angiogram. And you can see a little ectasia in the iliac vessels. And I think already you can see the very significant calcium in the common femoral artery. Here's another oblique view. Pretty big vessels. And now with an Ansel crossover sheath, we can see what I think is pretty clearly tight significant stenosis. Here's a non-subtracted view. Another oblique view. And here's our runoff angiograms. Very big SFA, relatively small profunda, some that looks like it feels probably from collateral from the hypo system. and delayed significantly, but good 3-vessel runoff.
Probably because of the cardiomyopathy, right? So, also.
Yeah, I think you're right, a combination of things. And then we'll talk about later whether you think protection is good or not, depending on what modality we use. And then I want to show you one more thing before we go, because this was going to be maybe a deal breaker if it was completely eccentric. Here is a picture, and if you will, let's show the IVUS images now, please. So go ahead and put those up with the fluid. Perfect. Okay. Maybe go to the, that's fine. All right, so go ahead and run the IVUS images, please. Starting from proximal to distal. And I think everybody will agree, pretty significantly calcified, pretty tight.
Yep, and eccentric.
And fortunately or not, fortunately, what's that?
Eccentric, very eccentric calcification.
It's a combination of eccentric, concentric. All right, and then let's look at our diameters. That's proximal. By CT angiogram, it's in the 9 range, 9 to 10, probably closer to 9. And then that was measuring 8.5. And then distal was very normal above the bifurcation and in the 9 and 9.1, 9.3 range. And then show us a lot of representative pictures of the very significant calcium. So with that, I'm going to turn it over to my salivating colleagues. If we're going to do it endo, and certainly any comments are welcome, let me just ask you as we get to work and a little bit, would you use distal protection if you were doing this endo, and what strategy might you use?
Just before we go there, we have Jay Matthews also on the panel. He just
I'm with you, my friend.
Joined in, so just to let you know, one more shark on.
Oh, good. Okay.
On the panel.
One more shark in the tank. Okay.
Yeah. So, panel, what do you think? Anybody from the panel?
Yeah, I mean, for these kind of exophytic type calcific lesions, I think embolic protection is absolutely essential, especially if you're going to do some type of debulking or whatnot too. Even potentially with shockwave or IVL, you can still have the theoretical risk of liberalization of that material. So I think there's very little to lose by putting embolic protection down.
All right. I think which he did already, I think. Anybody else?
Yeah, you can see it on the screen there.
Yeah.
It does certainly look like it, and I guess what are you going to do about the profunda, though? Because obviously, you don't want to lose that. In my mind, that's one of the 2 most important arteries in the leg. And I think there's also, some discussion there. He's not going to do well with plano balloon angioplasty. I would think that, intravascular lithoplasty may be shockwave may be a game changer in these type of lesions. And I've certainly used atherectomy knowing that I'm going to embolize doing it. But here you have someone, and I have to wear my surgeon's hat here. You have someone that you just said you're trying to fix him so he can climb up and down the stadium cheering for whoever there is down there. I don't know about say Alabama.
Tennessee Vols.
Somewhere north of Alabama in Luis. But, if that's why you're doing it, then he probably can tolerate a little local groin incision and an endarterectomy of this very significantly calcific eccentric plaque. So I would readdress the surgical options. Obviously, you did multiple times. He was discussed with your vascular surgeon. And so I would proceed, but I think probably try the shockwave first.
Anybody else? Any comments? Or
maybe it could be nice also to have an angio with the hip flex, because this gives you a little bit more information about the flexibility of the vessel in that area. This is a pretty young patient, and I think we have to think what could be a complication if we are doing, debulking, because then it could be a problem for him.
That's right.
Chris, this is Darren. I had one question for you on the angiogram.
Yeah,
I thought I saw a whiff of what was main profunda that may not be filling early and was filling delayed, and that certainly is something that I take into consideration when I'm deciding endo versus open, because with open we can certainly repair that as well and restore patency to that.
And Darren, that's, you're so keen on this. I did not see that the first time around. I will show you on the runoff exactly what Darren's talking about. And I saw that too, and I doggone it. That's not exactly what I said, but if you watch here, there is a whiff there. Now, I wasn't sure if that was coming from the hypo system, but you are right that there is some delayed filling up there. You're spot on, Darren.
And he's probably got a lot more seasons of Tennessee Vols games to go to, and he's relatively young, so I would factor that in also.
Yeah, no, I think there's, and I will tell you this, we're going to go up to 1. We're going to try to, even if this works or doesn't work, is if we don't do something stupid, which I have my team here counting on me not doing anything stupid, we don't take options away. And remember, EF was pretty darn low, 25%. And I know a good surgeon is going to do just fine with that 3.
So
EF's probably way better now that you fixed his coronary, so.
It is, although we checked that, and it did get better, but I needed that on my slide to keep you guys off my back.
I know Dr. Schneider is trying to push the discussion towards where it has to go. I see that going in, but before we go there, Chris, I know you already doing a shockwave. I think that's probably your plan. My question was, as Dr. McKinsey said, why any reason why you didn't choose an atherectomy device, or?
Yeah, so we really wrestled, and if you'll swing over here to our table, go.
I saw a hawk on the back.
We had the hawk versus shock debate at 5.
Okay.
And we still may, and I just think the risk of embolization, and if we don't do anything dumb here, I think we have wide open options, including DCB and so on. Come on down.
Okay.
So, I think that we have that, and even here, we still could add this as complementary therapy if we needed to, but we'll just be very careful with that. But it's a good combination. I know, Jim, you're a pretty big hawker. I mean, not hawker, but you know what I mean. You use the silver hawk.
Yeah. Stop smoking. I don't do as much, so, yeah.
I'm not saying that because of what you said about the Vols either, that hawker thing. I mean, you like silver hawk, go up to 1. What do you think? Would you go with that front line, or would you go with the? I think the luminal, because this vessel's bigger, it influenced me a little bit.
I think IVUS tells you also too, because if the plaque is eccentric versus concentric, with the shock wave, you're going to have to do more pulses in order to be able to get a good result. So I think that also kind of helps define which way you want to go.
Yeah, I was going to ask how many pulses you're planning to use, and I like how you centered the detector or emitters there, so you had the maximum amount of pulses right at that calcific plaque. But I think if we couldn't do a surgery, I think a directional atherectomy device would work. But I do worry about showering into the profunda.
I do too, and
Chris, I think the sheath, I know that you put a flex sheath. Is it an 8 French or a 7 French sheath?
No, it's a good question. So I like to prepare for everything. So we put an 8 French Ansel sheath. And the reason is, I want to be prepared for anything and everything if we can. So bailout equipment, some of the devices we might need to use. Come on down. I would rather have one more French that lets me do whatever I want. If we've got protection system here, and I want to use a big DCB, I could put an 035 wire adjacent to the protection wire. And I just think it gives us more options. We have a 10 and a Vibon over there in case that came into play, all those things. So we use bigger. I think bigger is better. If I'm going to do this case in front of you all, I want to have plenty of support and options available.
Chris, one last question, and I'm kind of impressed by the kind of isolated lesion that you have there. I mean, you saw the runoff, that looks pretty good. The other side looks pretty good. I know he's had carotid coronary interventions. Most of us are right-handed. Most of us would access the right side. Do you know what kind of closure devices, or were they being used or anything in the past? Because I'm wondering if we're not having some response to closure devices here, too.
Come on down. So that's a great question, Jim. Come on down. I did his interventions, and the last time I saw this, and I went from his right. I'm a short right-handed cardiologist and carotid center. So I give the right, and so I for sure didn't close that. Now, he had met another one of my partners in 2014, and I could not find any evidence of a closure device there because there was calcium, so it said no closure device. So I don't think there's ever been a closure device here. We're going to do one last pulse here. Go up there, please.
And I see, Chris, you're dilating the shockwave device. I think you started off with low pressures, gave pulses. I think this is probably the eighth pulse you're giving it. So I think
let's see. We have yes, I'll tell you in just a moment. The cycles we're going to be down to 150, so we've used 150 cycles. I'll let somebody do the math there. Now, remember the M5 Plus, it does 30 cycles in 15 seconds, which is nice when we're doing these discussions. Come on down.
Right.
I think that's going to be enough shockwave. Anybody else think anything different? I think it's expanded reasonably well. We can do one more for you, but and then after that, we're going to stop. I don't want to have the balloon dissect anything into the ostium.
Just a question to the panel. Would you guys,
yes,
any of you guys would have atherectomized first and then shockwaved it just to debulk the lesion a little bit, or directly? What would have been your response?
I would probably do the opposite.
The opposite side.
I would shockwave it to see what kind of results I get. Do it like he's doing it now on just real fluoro, and you can see how much the balloon's expanding at every series of pulses you've given. And if you keep seeing getting a little bit more and more luminal gain, I'd be happy with it. If I didn't get a good luminal gain, I'd say, okay, now I'm going to step it up, and I'd come in with a directional atherectomy device.
I think it depends on the morphology of the plaque as well, too. So it's pure calcium. And, I think the upfront shockwave and then figure out what you need to do afterwards makes sense. And then the other way around, if it's heterogeneous, there's mixed softer material with severe calcium. In those kind of scenarios, I tend to use some directional laser, like a turbo power laser, then combine it with a shockwave.
And question about the atherectomy devices. I know there'll be mixed consensus, but I know there'll be Silverhawks. Anything else? Jetstream? Anybody would have gone with the Jetstream? Or pretty big, or everybody would have probably agreed with the Silverhawk because it's eccentric?
Well, I'd like to probe further with the laser. Are you putting contrast and kind of doing a Thor type of maneuver, or little controlled explosions?
Before I had shockwave, I was doing that. But the problem with that is it's uncontrolled. It's about 100 atmospheres, and shockwave is about 50 atmospheres. 100 atmospheres in the common femoral can lead to some very exciting results, not in a good way. And so in that situation, you probably are going to end up having to put a stent in, and I'll talk about this in my talk, the data with scaffolds in that area, especially the biomimetic scaffolds, is actually very good. But, I still fall, even despite the data, I still believe less is more, and I try not to leave anything behind, because if you do need to do an endorectomy down the road, it would be nice to not have to deal with a big stent in the way.
So I think back over to you. I think it's a good result, shockwave.
So I'd like to get everybody's opinion. So the one nice thing, there's no dissection. Clearly the lumen is a lot bigger. Now, it's not perfect. It's not what Jim McKenzie or Darren would have done with a scalpel. All right, and I can't believe I'm saying that, but I do believe it. But it's going to get him walking. Now, I think what we're going to do, now I'd love to get opinions. I think we could get super cool and IVUS and then use the hawk that we've already paid for. I think we're going to go with a DCB here. And just, go a little bit bigger with a DCB, having prepped it with this, go up very slow, and then check an IVUS and a gradient and go from there. Does that sound reasonable to the panel?
I think it sounds reasonable and definitely safe in terms of embolization and other risks. I do have concerns with this eccentric lesion that if you looked again in 20 or 30 minutes, that there'd be some significant recoil potentially. So,
reasonable question. And concentric would be much better.
The other question I have is, you said check a gradient. Well, he's already proven that, he may have a near normal pressure, or at least an ABI in the 0.7s at rest. And so unless you're going to put a vasodilator down there too, you may get a false sense of success. And once you dilate him up, you may see there's a greater pressure drop.
And Chris, the DCB you're choosing here is 7.0?
It's a Medtronic. It's a Medtronic 9x40.
9x40. All right. Even though you felt your vessel was, the IVUS sizing of the vessel was 8.4, 8.5.
So on CT angiogram, it was at least 9.
Okay.
So on 9. So we had our IVUS, the distal one was 9.2, 9.3. CT angiogram was more in the 9+ range.
Okay.
And the proximal one that you saw there, so show them the distal end there, Josh. And would you show that for the IVUS? There you go.
Oh.
Yeah.
So leave the floor up as we go up very slow.
The expansion seems pretty good.
Now, it's not going to be perfect, and if I go for perfect, I think we're going to get a dissection.
Yes, Jay.
It limits your, obviously your scaffold options too then.
Yes.
Right? So that's the problem. I mean, Supera has some of the best data here, but unfortunately we don't have a appropriately sized scaffold that can fit in that space.
Yep. That limits us.
You know, they've done a great job with a 7.5 Supera, but that's too small, I think, for this.
Yeah.
And Chris, I'll just, poke the skunk here. If you want a perfect result, call Darren and we can come fix that for you.
I think
You know, when I think of you, I think of skunk, Jim. So thanks for poking your brother there. No, I think it's fair enough. Hey, welcome back. So let's go back to our fluoro, please. Okay, so we did a 5-minute, so you're perfect. Thank you for the timing, by the way. That was perfect to go to a talk so we could do a true, good, long DCB. So there's that 9 DCB for a long period of time. Here's the angiogram after that. Again, no dissection. You know, is it perfect as Darren? No, but it's pretty darn good. And the flow in that profunda is now robust. Okay. Next, we'll do an IVUS, which we'll show you now. So go ahead and split the screen, do the IVUS. Go ahead and roll the IVUS, please. And again, you remember how tight that was? There was a few areas of eccentric calcium, but really no dissection, and overall looks very, very good there into the SFA. And now let's show you the hemodynamics. So let's go to the now flip the button. So go back, unflip it. So the purple is his nicely treated heart failure with a blood pressure systolic of 100. Now I'm going to flip with a catheter across that. Go ahead and flip it now, Michelle. And they're superimposable. And so, the point earlier, this is resting scenario. I get it. But I think with an IVUS with no dissection, a very nice lumen, no gradient, I think we're going to call that a happy day. Remember, there's drug on there too, so let's just take this out. You can take that off. What we're going to do now is we'll take the basket out and then do a runoff if we have time for that. However it works best for you, if you want us to take the basket out, show you the debris and run off later in a 30-second clip after you do a talk, however you want to do it, it's fine with me.
I think panel has any questions in the meantime. He takes a picture, or what do you guys think about the final result?
I mean, I think it's a very reasonable result. Another great job, Chris, as always. And even as a surgeon, I have disclosures to make that I do some endovascular treatment in select cases of common femoral arteries when I think that that's appropriate. I think one of the issues is, and this is a kind of push to industry, is that we don't necessarily have the right devices for the common femoral artery in terms of sizes for scaffolds if we want to use them, and maybe novel technologies that we can treat bifurcations better. So I hope that industry is going to provide us with some of that so we can do this even better.
Yeah, I think you're right, Darren. Because a big Supera, a 9.0 Supera, would be perfect. A lot of common femoral arteries do lend themselves to Supera, as you know, and as we've heard. This is not one of them. It's just 7.5 Supera is just not big enough for this artery. So here's our NAV6 device that we'll take out, and then we'll do a runoff.
So just a question.
But your points are well taken.
Yeah, if you had a dissection, at least, I mean, I can't say flow limiting in this vessel size, but if you had a dissection as a panel, or Chris, what would you guys have done? Probably just left it, watched it, because you have drug
depends on how bad that dissection was. I think if we really had to, we'd put a big Viabon in it. But the nice thing, I don't like covering a lateral circumflex and inferior epigastric either. So that's probably what we would do. I think nitinol stent here is a terrible idea. I don't do it unless there's absolutely no other option. I don't remember the last time if I've ever done it. Let's do our lateral lock. So I think that's a terrible idea. So we'd maybe do a Viabon 10 by 50. Or a 7.5 Supera. We'd have to really think about it. You ready?
Right. Finally, you wanted to say something?
I mean, I think this is the best result that you can achieve in this condition without the atherectomy, because obviously calcium, I mean, in this case, you have like a rock within the vessel lumen. And there is no way to improve the vessel lumen, if you do remove it. So I think it's pretty okay.
To your question about a dissection, it depends on you said, well, non-flow limiting. So if you've got a dissection and with an I have actually excised the dissection flap with a directional atherectomy device too. And so that's another option if you come in. Now, when you get up to 9 millimeter vessels and things, then it's really it's outside of the atherectomy devices that we have in most cases. So, and I would definitely want to use a directional atherectomy here. So I think there is still some things you can do, but I'd be concerned about the Viabond because if you're off, you cover the profunda, and then you've got a real problem.
We're not going to be off. You're right.
And that's a good point, Chris. You won't be off.
So let's take one runoff.
Go ahead.
And then
I'm off to begin with. All right, so here's our final runoff. Get down there, Jessica. I can't help but backseat drive, even though they do it much better than I do. But there's good runoff. Don't see any distal embolization. Don't move. Don't wiggle, sir. You're doing great. Don't move or wiggle. Stay on it for just a moment. All right, and you can see we really have a talented team here. I can backseat drive with the best of them, but they can front seat drive a lot better than I can even backseat drive.
I think that's a very good result for what we started off with.
Agreed.
Hey, panel, any comments? I think, thank you, Chris. Really appreciate it. Fantastic result. Congratulations.
Thank you all very, very much.